SNES infection in HIV patients. Int.Nayanantadol Saich 24th of June 2013. Outline approach common diseases, basic knowledges. Medical treatment. Surgical indication. Take-home messages. How to approach. HIV patients can acquire both opportunistic infections and others found in normal host. Workup should be extensive due to the possibility of multiple infections. However, opportunistic infection should draw attention firstly. How to approach. Algorithm. How to approach source, HIV-associated opportunistic infections of the SNES. Lancet Neural 2012. 11, 605-17. How to approach. Lesions can be categorized into three types based on radiological appearance. 1. Focal mass. 2. White matter disease. 3. Meningeal disease. How to approach focal masses. Focal masses with REM enhancement. 1. Toxoplasmosis. 2. Tuberculoma. 3. Cryptococcoma. 4. Primary SNES lymphoma, not infection. 5. Bacterial and fungal abscesses. 6. CMV encephalitis, rarely. How to approach focal masses. Focal masses without REM enhancement. 1. Toxoplasmosis. 2. Cryptococcoma. 3. Atypical primary SNES lymphoma. How to approach white matter disease. 1. HIV encephalopathy, HIV-E. 2. CMV encephalitis. 3. Progressive multifocal leukoencephalopathy, PML. How to approach meningeal disease. 1. HIV meningoencephalitis. 2. Cryptococcal meningitis. 3. Tuberculous meningitis. 4. Other bacterial/viral meningitis. Common diseases. Toxoplasmosis principally in HIV patients. 15 to 40% of AIDS patients. Usually occurs when CD4 less than 100. Almost always a reactivation and serology is positive in 85%. Seronegative cases occur as a result of immunosuppression or really a primary infection. Toxoplasmosis common sites. 1. Basal ganglia. 2. Corticomedullary junction. Usually frontal and parietal lobe. 3. Brainstem. Meningeal involvement uncommon. Toxoplasmosis diagnosis. 1. Imaging, CT MRI, REM enhancing lesion. Typically 1 to 2 centimeters. Less than 20% solitary. 2. Serology, IG, IM. 3. PCR. Toxoplasmosis. Toxoplasmosis treatment, pyrimethamine plus sulfadiazine 6 weeks. In cases of failure to diagnose or respond to medical treatment within 7 days, biopsy is needed for tissue pathological diagnosis. Secondary prophylaxis until CD4 greater than 200 for 6 months. Tuberculosis found in both immunocompromised and immunocompetent host. HIV patients are prone to develop reactivation and extrapulmonary infection. Tuberculous meningitis and tuberculoma/TB abscess, uncommon. Tuberculosis CN3 palsy involves cerebral artery which can produce focal ischemia. Tuberculosis diagnosis. 1. CSF profile, mainstay for DX. AFB plus vein 1/3. 2. Imaging, CT MRI. Tuberculosis diagnosis, CSF profile. Tuberculosis imaging, CT MRI. Leptomeningeal enhancement mainly at the base of skull. Tuberculoma at basal ganglia. Communicating/non-communicating hydrocephalus. Tuberculosis imaging, CT MRI. Tuberculosis treatment, HRZEX 9 months or more. Steroid reduces morbidity. In case of hydrocephalus, extraventricular drainage or shunt is required to reduce ICP. Cryptococcosis usually develops when CD4 less than 100. Forms, meningitis/cryptococoma, pulmonary, skin and soft tissue. Meningitis may be absent. Complication: CN deficit, visual loss, cognitive impairment. Cryptococcosis: poor prognosis, plus VA Indian Inc., high CSF pressure. Low glucose. Low pleocytosis less than 2 cells/3. Extraneural yeast cell. Absence of AB. CSF or serum crypto. Ag greater than 132. Steroid use. Hematologic malignancy. Cryptococcosis diagnosis: 1. Indian Inc. 2. Cryptococcal ag in CSF/serum. 3. Imaging, CT MRI, cryptococcosis. Cryptococcosis imaging, CT MRI, hydrocephalus. Meningeal enhancement. Cryptococcomas at basal ganglion. Punched out cystic lesion, cryptococcosis. Imaging, CT MRI. Cryptococcosis treatment. AMP. B 0.7 to 1.0 mg/kg/day 2 weeks and then fluconazole 400 mg/day for 10 weeks. Repeated LP or shunt is necessary to relieve increased ICP. Secondary prophylaxis until CD4 greater than 200 for 6 months. Primary CNS lymphoma. Frequently occurs in severe immunosuppression or AIDS. High-grade B-cell lymphoma. Strongly associated with EBV. Poor prognosis compared to similar lymphoma outside CNS. Primary CNS lymphoma imaging, CT MRI. REM enhancing or heterogeneously enhancing. Usually greater than 3 cm. Paraventricular, frontal, temporal. Difficult to distinguish from toxoplasmosis or metastasis. Primary CNS lymphoma. Diagnosis usually made after failure to respond to toxoplasmosis RX. Brain biopsy is mandatory to obtain tissue pathology. If safe to LP, CSF for EBV DNA help to diagnose with no need to perform biopsy. Primary CNS lymphoma. Imaging, CT MRI. Primary CNS lymphoma treatment, CMT plus WBRT. Greater than 90% have a recurrence disease. Surgical resection, for immediate decompression of life-threatening mass effect. HIV encephalopathy, HIV-associated dementia. Symptoms: progressive dementia, cognitive impairment, motor symptoms, gait disturbance, tremor. Subcortical dementia, no aphasia, apraxia or agnosia. Alertness is minimally perturbed. HIV encephalopathy. Diagnosis: 1. Imaging, CT MRI. 2. CSF profile, HIV encephalopathy. Imaging, CT MRI. HIV encephalopathy CSF profile. Non-specific increased in cells and protein. Helpful in diagnosing or ruling out HIV RNA not correlate with HIV encephalopathy. HIV encephalopathy. Treatment: heart. CNS resistance may occur. CMV encephalitis usually occurs when CD4 less than 50. Reactivation of latent infection. 2 forms. 1. Encephalitis, progressive dementia. 2. Ventricular encephalitis, CN deficit, alteration of consciousness, nystagmus, disorientation, ventriculomegaly. CMV encephalitis diagnosis: 1. CSF, PCR for CMV DNA culture. 2. Imaging, CT MRI. Paraventricular enhancement. No calcification like congenital CMV. Subependymal enhancement. -50% normal imaging. CMV encephalitis. Imaging, CT MRI. CMV encephalitis treatment, ganciclovir, valganciclovir. Induction of 14 to 21 days followed by prolonged maintenance therapy. Secondary prophylaxis until CD4 greater than 100 for 3 months. PML caused by the reactivation of the Jamestown Canyon, JC, virus. CD4 counts usually below 100/3. Multiple areas of demyelination throughout the brain sparing cord and optic nerve. PML. Symptoms: visual loss, mental impairment, weakness, ataxia. PML diagnosis: 1. MRI, multifocal asymmetric white matter lesions. Subcortical white matter, cerebellum. Low signal on T1 weighted images and hyperintense on T2 weighted /flare. PML. Diagnosis: MRI. PML. Diagnosis: 2.CSF, PCR for JCV DNA. Normal cells and protein. HSV encephalitis. HSV produces necrotizing encephalitis in HIV patients. Predilection for the medial temporal and inferior frontal lobes. HSV encephalitis diagnosis: 1.CSF, PCR for HSV DNA. Senators 96% and SPEC 99%. Equivalent or exceed brain biopsy. May be negative if too early, less than 72 hours, or more than 14 days. HSV encephalitis diagnosis: 2. Imaging, CT MRI. Area of low absorption, mass effect or hemorrhage on CT. Hyperintensity signal on T2/flare or diffuse weighted. HSV encephalitis. Imaging, CT MRI. HSV encephalitis. Treatment: 4-acyclovir 10 mg/kg Q8 hours for 14 days and repeat CSF profile. Dilute less than 7 mg/ml and infused slowly over 1 hour to minimize renal dysfunction. Take-home messages. Neurological manifestations in HIV/AIDS patients have a wide spectrum. Clinicians must consider multiple causes which share similar clinical and radiographic patterns. Neurosurgery carry an important role for diagnosis and treatment. References: Human Textbook of Neurosurgery 6th ed. Harrison Textbook of Internal Medicine 17th ed. Lancet Neurology 2012.